The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, and we're dealing with a very timely topic today. We're talking about measles. It's interesting because there are some diseases that sound like they ought to be old diseases, but it turns out that old diseases become new diseases again, especially in the current environment. It seemed like a good idea for us to talk about measles. Has been around for a long time, but most people have never seen it. And so it's an important thing, I think, for us to get up to speed. We're very fortunate this week to have three guests, all from the Division of Infectious Diseases at the University of Utah. Our three guests this week, our lead guest will be Dr. Mary Fortini. Next week, Dr. T.W. Jones. And then a familiar guest who will take the lead in the third week is our old friend, Andy Pavia. Now, we should note that they're all here through all the episodes, and we'll probably hear from all three of them. But in order to try to keep things as uncomplicated as possible, we're having one person take the lead each week. Mary, let's introduce you a little bit first. So you went to medical school in Kansas City, then you do residency in Nebraska, and then off to Baylor for fellowship?
That's correct, yes.
How long have you been in Utah?
So I've been in Utah since August of 2022, so just for a few years, coming up on 3 years.
Well, glad to have you here. Tell us, what are your clinical interests and what do you like to do outside of medicine?
Yes, so in addition to seeing patients on the clinical service, both inpatient as well as outpatient, I also work with Andy Pavia as well as one of our other infectious disease specialists, Emily Thorell, in hospital epidemiology. So I'm really interested in helping prevent central line associated bloodstream infections and helping with hospital preparedness specifically for pathogens of high consequence, such as things like Ebola.
Oh, sure. Yeah, well, let's hope we're not doing a quick episode about that in the next couple of months.
Yeah, hopefully that's a never event.
Exactly. And do you have any disclosures?
I do not, no.
And just in passing, TW and Andy, any disclosures we should mention?
I do not have any financial or other disclosures.
So I do. I've been a consultant for Halion, which makes outpatient products unrelated to this, and I'm an editor of the Sanford Guide for Antimicrobial Therapy, so I get royalties from them. And then I'm passionate about preventing infections in kids, so I have to disclose that.
Well, everyone has to have a weakness, I suppose. Anyway, let's put measles in context. Now, part of the reason why many people haven't seen the measles before is, Mary, if I'm not mistaken, the Americas were measles-free about 10 years ago.
Yes, and we can actually go even back a little bit further. Specifically within the United States, measles was declared eliminated in the year 2000. And in order for them to get that status, it means that they should have not have had measles transmission from the United States in at least a year's time. And so going forward to 2016, when we talk specifically about the Americas, yes, the WHO did declare all of the Americas measles free in 2016. However, I will say endemic measles had resurgence in transmission in Venezuela in 2016, as well as in Brazil a couple years later in 2008.
So as it turns out, now we're hearing about the measles in the news all the time. What happened?
Yes, so it started in a small community in Western Texas in the beginning of this year in January, where it was specifically under immunized community. And measles is highly contagious. And so, for example, if you put 10 people in a room with somebody who has measles, 9 out of those 10 people will have developed measles. And so it's highly transmissible. And within that community, you've seen that there's been lots of outbreaks since then. And so the CDC has been keeping up to date as far as health departments reporting to them about confirmed cases. And as of yesterday, they have 1,088 confirmed cases in about 33 states. So you can tell how contagious this infection truly is.
Over what period of a measles infection is it so contagious?
So Measles, and we can talk about the symptoms in a little bit, but it's typically 4 days before you get the rash, in addition to 4 days after the rash. So it's essentially about 8-ish days in which a person can be contagious.
And that period before the rash appears, is this a period where the person with measles is going to appear quite ill? At what point do they start transmitting?
Yeah, it's a great question. So typically, the first signs and symptoms that they have, it's called a prodrome. That's also known as early symptoms. And so they develop a fever. The fever can actually be quite high, up to sometimes even 104 degrees. And they can develop the 3 C's in addition to a fever. And so the 3 C's, the one is cough. The second one, it's coryza, and that's just a fancy word for saying essentially a runny nose. It's inflammation in the nose that causes kind of irritation and a runny nose. And then the third C, it's conjunctivitis, also known as just red eyes. And so these early symptoms typically last anywhere from about 4 to 7 days. The fever can last about 4 to 7 days. And as you can imagine, lots of people who go to the emergency department can have symptoms that develop that can look very similarly to this. Lots of viral upper respiratory infections, specifically in younger children, that may be misdiagnosed as not measles at the time.
Well, especially if we're not looking for it, right?
Correct. So we talked about the prodrome, and then some patients can also develop what are known as Koplik spots. And whenever people think of Koplik spots, they tend to think about measles. And what these are is, again, it's a fancy name just for saying they have these bluish white spots inside their mouth with almost a red halo around these spots. It's on the inside of their cheeks. Some people will describe it as grains of salt on a red background. And these spots typically occur about 2 to 3 days after you have those initial symptoms. And then the most prominent symptom is this rash, and it specifically starts at the head and goes downwards to your toes. And that typically occurs about 3 to 5 days after you get the onset of your initial symptoms.
And the child continues to look ill through the whole time.
Correct. Yes, people who have measles look pretty sick and pretty miserable.
I was going to say, I often teach the medical students and residents that the fourth C is crappy because kids with measles don't look like they've got an ordinary cold. They're miserable.
And that's an important thing to take into account. So, of course, the nightmare, I think, for any pediatrician, any emergency department is how do we effectively steer these patients since it is so highly contagious? How do we identify them and keep the other patients safe?
Yeah, that's a great question. And again, as we talked about, it is such a contagious disease where we really want to prevent people who are infected, want to prevent them from going to areas where there's lots of people, such as emergency department waiting rooms, in addition to outpatient clinic waiting rooms. And so the most important thing is determining someone's vaccination status. And for the measles, mumps, rubella vaccine, it's 2 vaccines that you get. And 2 vaccines gives you about 97% protection against developing measles, which is absolutely fantastic. 1 vaccine will give you about 93%. So I think the initial area of prevention is making sure that your patients are vaccinated when they need to be vaccinated. Other things is if people are not vaccinated and they develop these concerning symptoms, to have them actually phone in to either their pediatrician or the emergency department to give them a heads up, just say, hey, I'm wondering if my kid has measles, they're having these symptoms, so that people are prepared.
Climate where there is this spreading outbreak, we need to be sensitive to that as we're making appointments for people, that as we're bringing somebody into the clinic, that we ask questions we may not have asked in the past.
Correct.
Now, if I remember correctly, the scheme that made 5th disease, if I remember correctly, measles is identified as first disease in that scheme. So it's one that has been very common in the past. Why should we worry about getting the measles?
Yes, so there are various complications that you can have from measles, not only of yourself and of your children if you're under-vaccinated or unvaccinated, but also in populations that are not able to be vaccinated, that are more vulnerable to developing severe complications, such as small children, infants, and also those who are immunocompromised, such as those receiving chemotherapy. Some of the common complications that you can get from measles are ear infections, pneumonia, in addition to diarrhea. However, severe complications that could ultimately result in increased morbidity, but also mortality, would be things such as encephalitis, which is a fancy word just for saying inflammation around the brain. And so people who get measles, as far as the stats for how many people can get these severe complications, such as encephalitis specifically, they talk about 1 in 1,000 cases. And there is something called subacute sclerosing panencephalitis, which is a long kind of diagnosis. That's something that doesn't come until a little bit later. It's about 7 to 11 years after they get infected. And so what
Oh,
that
really?
is it's a rare.
Oh, really? So that's a late complication, a very late complication.
Correct. And what it is it's a rare degenerative disease of the brain that occurs that has a high incidence of mortality. And I think, along with these neurologic complications, including the encephalitis, things that you can see associated with that would be seizures, ultimate intellectual disabilities, hearing loss, and like I had alluded to, even mortality associated with these.
Yeah, Paul, I think one often hears that, it's a childhood illness and therefore not very severe. And we've heard that from even people in the government. But that's a misnomer. Chickenpox is not a very severe disease. The common cold's not a severe disease. Measles is a bad illness. Before we had a vaccine, when the population of the U.S. was a third of what it is now, about 500 kids died every year of measles, and most of them were perfectly healthy, well-nourished kids who died of measles. In countries where malnutrition is really common, measles kills thousands upon thousands. And unfortunately, I've seen it.
If I can tag on to what Andy said, those mortality figures are coming from a time when there were a lot of individuals running around with natural immunity to measles. When measles strikes in a population that has not seen it or is under-immunized or has not seen the natural infection for years or never, it's devastating. We often talk about, smallpox devastated indigenous populations in the Americas, but we're missing out that measles played a huge part in that too. And there's a huge record of measles deaths in under-immunized populations around the world.
Yeah, for those of us here in the West, it's worth remembering that measles contributed to the massive die-off of Native Americans when Europeans came.
And that's a part of history that we don't talk about enough, I think, is that exposure to new diseases decimated the indigenous population. Yeah. A few months ago, I talked about Perry Klass's book with Angelo Giardino. Perry Klass's wonderful book, A Good Time to Be Born. And I think it's very instructive because I think we think back and say, yeah, people died, but how bad was it? And it was bad. I think that to assume that it was not tragic, it was horribly tragic, that families expected that not all of their children would outlive them. And I think that to underestimate the resurgence of a disease like measles is, I think, both an ignorance of history and I think a sort of cavalier attitude that's tragic in the extreme.
Yes, I agree. And I'm sure you've heard so far in this outbreak that we've had that started in Texas, we've had 3 deaths. 2 in children in Texas who were reportedly previously healthy, school-aged children not vaccinated. And the third one was an adult in New Mexico who was unvaccinated as well. And so we still see mortality from this even in the post-elimination era, where it's anywhere from 1 to 3 deaths per 1,000 cases.
That's a lot. I mean, to put that
It is
put
a
in that
lot.
context, you put that in the context of something like RSV that I think feels like has a great toll on a population. It much more than that.
Yes.
Yeah. So one other thing, you talked about both an under-immunized population and a population that hasn't been exposed for a while. In a population where people have immunity, either natural or acquired, is there a booster effect from having been around natural measles?
So there is something that we call herd immunity. And so what that means is that enough people have either had the natural disease or have been vaccinated to a point where transmission of the virus within that community is very shortly lived. And so the required herd immunity in order for that to occur, specifically for measles, would be 95%.
But Paul, I think you're asking about something a little bit different. So with chickenpox, you don't get lifelong immunity from a single exposure, but we believe that adults used to get boosted all the time by being around children with
Right.
chickenpox, and so their immunity was revved up periodically. Measles is a little bit unique in that it does provide lifelong immunity in the vast majority of people who've had it, even without re-exposure. But probably re-exposure gets that efficacy up from that 97 to 98% and gets it even higher.
And for people who were immunized a few decades ago, does that immunity tend to last asking for a friend?
So it does tend to last, I will say, unless if they have been vaccinated between the years of 1963 to 1967, because the vaccine that was used afterwards is the one that is currently used. And so that provides lifelong immunity. However, within those years of 63 to 67, it was a little bit of a weaker vaccine. And so if you were vaccinated during that time, we would recommend that you get the full vaccination with the current vaccine.
And some people may have only gotten a single dose. In 1969, we saw a great deal of breakthrough infection. Sorry, that was 89. Yeah, the time flies. I was around for both of those. And we saw a great deal of breakthrough infection, people who had a single dose of vaccine. It wasn't huge, but enough to learn that everyone really should get a series of 2 doses and not 1. So if you were vaccinated before 1989, it's worth checking to see that you actually got your second dose.
The trouble is, I think, how do you check? We're fortunate in Utah these days that we have a registry where stuff gets posted, but it may be difficult for people outside an area where there's a maintained registry to know what they've had for immunizations. Behooves us to try to figure that out. So, reviewing what we've talked about, measles is bad disease. And, the fact that it sits clustered with other childhood diseases, the thing to remember is that some childhood diseases actually were lethal for children. This is one of them. And it's important for us to keep that in context. As you've mentioned, we're going to talk a lot more about the vaccine next week, that we have an effective vaccine that has changed the course of history for the past few decades, and we stand at risk of losing some of those gains. And that in the early period, measles can look like a lot of things, but it's important for us to remember that with high fever, cough, runny nose, conjunctivitis, and a sick-looking child, we need to think about that because it could be the period before the rash actually happens. And then that once a child has the measles, aside from the fact that they may be very ill from the illness itself, that it has a significant rate of complications. Did I learn anything this week, Mary?
Yes, exactly. I was just going to say that was a great summary.
All right. Anything you want to add about measles, the disease?
So often when I'm teaching residents or medical students, I tell them without hyperbole, you can say this is the most contagious disease you could ever encounter. It's not necessarily like, Dustin Hoffman in a hazmat suit kind of, scary, but it's certainly up there. And it definitely is one of the most contagious things out there.
Very contagious and also carries a fair amount of danger.
There's one other thing perhaps to add that's really interesting about measles and quite unique, and that is that it targets memory B and T cells. And so anyone who's had measles has a period that lasts from a few weeks to a few months when they've lost a lot of their pre-existing immunity to other infections. And so you can see secondary infections occurring well after you've recovered from measles because of this immune amnesia, as it's called. So it does substantial damage to your immune system, which we think mostly recovers, but it takes some time.
Is that why the rate of secondary infections is high?
Well, there's probably 2 reasons. You probably get secondary infections early on because of direct damage to the mucosa and to the lungs. Mm-hmm. And then you can get these late secondary infections from this immune amnesia.
Yeah, that's not a good thing. All right. Well, on that cheery note, we'll plan next week to talk about the vaccine. And then in the third week, we'll talk about some strategies about what we should be doing perhaps differently during an outbreak. Mary, TW, Andy, thanks so much for your time this week. I'm sure there will be questions. There are so many questions about measles right now. Please send your questions to questions@vcurb.com, and we'll deal with those in a couple of weeks. And tempt you back, all of you, next week.
Thanks for having us.
Thank you.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Phil Wirkus, who also composed the theme music. See you next time.